It's my pleasure to welcome Dr. Richard Quinton. We're really lucky to have him today, and he's going to tell us everything we need to know about management of female hypogonadism.
Okay, so many thanks for the kind invitation, Amir. So this talk's based around the UK guidance that came out in 2004, and I'm really going to try and give you the highlights. Where did we start before this? Well, there was some guidance from NICE in the UK, and also there's very interesting guidance from the Endocrine Society, from their guides related to hyperpituitarism. And so let's see what NICE said. Well, okay. I think there's a delay in the slides. What did NICE say? NICE said that women with POI are offered HRT or combined oral contraceptive. That's it. NICE guidelines have been updated, but they don't really say anything much more than that. And that's probably because not a single endocrinologist was involved in the NICE menopause guidance. And then the Endocrine Society guides for pituitarism. This is interesting things in 2016. So one thing was that younger women might prefer HR contraceptive pill to HRT, which actually is one of these factoids that is not actually based on any evidence. It's just doctors projecting onto patients their thoughts. It's not something any patient has ever said to me. So anyhow, women on all estrogen require high doses of growth hormone. Well, kind of. Actually, it doesn't really matter what you're on in terms of the ability of growth hormone to stimulate IGF-1 secretion. All that matters is that you're not on the pill, that you're not on ethanol, estradiol, aesthetic estrogen. Whether you're on nothing, whether you're on oral, whether you're transdermal, that still gives you better growth hormone-mediated IGF-1 secretion than the combined pill, although transdermal probably has an edge. So that's another bit of a factoid there. Again, the combined pill factoid, yes, absolutely. Studies comparing these regimens are lacking. Well, actually, they weren't lacking. In fact, on almost every count, HRT, even given quite crudely, outperforms the combined pill. Also, that there are a variety of modes of giving estradiol, transdermal, intravaginal rings and tablets and creams. And of course, intravaginal estrogen or tablets and rings is not HRT. It's to permit sexual function. It's like Viagra for women. It's not HRT at all. And so it's really quite astonishing what the Endocrine Society came out with. And these things really rather inspired us into from the UK guidance. But just to run you through what estrogens there are. So we have native estradiol, transdermally or oral, horse estrogen, conjugated equinestrogens, and also ethanol estradiol, which is found in most pills. Native estradiol you can pick up in an assay. Any conjugated equinestrogens in certain assays and others. Ethanol estradiol, the pill, you will not pick up in anything. Ethanol estradiol particularly tends to raise blood pressure. The others don't. It's a particularly potent growth hormone antagonist. If you're trying to do pubertal induction, it probably doesn't achieve a mature uterus. And certainly both the ethanol estradiol and equinestrogens are remarkably more prothrombotic. To avoid thrombosis, your best bet is transdermal, which has no risk. So here the guidance published last year, and our group convened during the COVID pandemic. Mixed group, endocrinologists, reproductive gynecologists, patients, GPs, and so it was a mixed group, everyone bringing their own points. But I really want to highlight my good friend and little brother Chanajaya Sena, who would be speaking here tonight, but is doing a PhD via in Copenhagen. And what do we want to cover? The biological effects of sex hormones, diagnostic classification, recommended investigations, and looking at lessons from natural menopause, from Turner syndrome, and also from transgender women. What we weren't going to cover was actually how to do HT for trans women, how to manage natural menopause, and how to do female pubertal induction, although we did draw lessons from them. Management strategies, We looked at disease-specific considerations, Turner syndrome, cancer survivors, hypothalamic amenorrhea. So this wasn't just POI. Other guidance is just POI or just Turner. This was the whole spectrum of female hypogonadism. We want to deal with practical troubleshooting problems, special circumstances, and we also dealt with fertility. So, mean age of menopause, currently 51 years in the UK, early menopause, loss of function age 40 to 45, POI under age 40, hypothalamic amenorrhea, a reversible form of functional central hypogonadism caused by suppression of the axis by either active disease process, stress, or a state of relative energy deficit. So how can we define hypogonadism? Now, you'll see a couple of double stars on some of the slides. And this is where I think we're saying things that are new, that others haven't really said yet. So it's amenorrhea in women between puberty and normal menopause. The endometrium, if you measure it, is thin, under 3 millimeters, which is very much unlike polycystic ovary syndrome. Doesn't matter what the ovaries look like. If the endometrium is thin and you're amenorrheic, it cannot be PCOS. The end. The endometrium suggests estrogen deficiency, hypogonadism. Low sex hormones. No other guidance wanted to say how low. We came up with a figure. I'll come to that later. And of course, sexual symptoms, if you've acquired hypogonadism after puberty, or if it was congenital, lack of secondary sexual features. You ask a Turner girl about symptoms, she said, how you doing? I'm fine. You won't get any symptoms out of her. What you haven't experienced, it's very hard to then describe as having lost. So an ovulation, obviously, and really crucially, there is no diagnostic role for progesterone challenge tests. They should be consigned to the dustbin of history. They provide no information beyond what you can get from ultrasound, endometrial thickness, or even easier, a serum estradiol level. And then give false reassurance when you've got a pathologically thin endometrium that you nevertheless shed. So dustbin. So what are the first investigations? So it's amenorrhea with an estradiol level under 200 picomole per liter. And I'll come out how we come up with that level later on. Plus other symptom signs and a raised FSH if it's primary. Remember, of course, that early stage POI may be stuttering with episodic regime relapse. So actually, even though levels may then normalize later on, it doesn't invalidate the original diagnosis. But you need an FSH to determine whether hypogonadism is primary, POI, versus secondary or central. And it's important also to try and determine the cause or at least exclude significant underlying causes. And really, genetics is going to come to the fore increasingly. There are 3 panels currently for the UK, one for POI, another one for congenital hypog, another one for combined pituitary hormone deficiency. And this is going to come to the fore increasingly as part of a routine investigation. So under primary, there's Turner syndrome, other forms of gonadal dysgenesis, autoimmune, single gene defects, iatrogenic, idiopathic. Under central or secondary, they fall into organic and functional. Functional hypothalamic amenorrhea is really common, but it can also be iatrogenic, progestins and opiates. Under organic, you've got the congenital causes, and you also have structural lesions such as paracellular tumors. So POI, age under 40, amenorrhea more than 4 months, FSH high on 2 occasions. Affects 10% of women under 40, 1% under 30, and 0.1% under 20 years. What investigation do for this? Well, obviously, karyotype, very important. You want to determine if it's Turner syndrome, in which case you really need an MDT clinic really supporting them. The ESHRA group just said you need a cardiology review. No, you don't. You need more than that. You need an MDT review. If there's Y chromosome material, gonadectomy. Fragile X testing, particularly if there's a family history and or intellectual disability. And then you want a geneticist to do the cascade screening of first relatives. Antibodies to give you an idea whether this might be autoimmune, risk of hypothyroidism, risk of Addison's, and these patients may need regular hormone testing. So hypothalamic amenorrhea, so you've acquired loss of urine excretion caused by weight loss. Usually there's disordered eating. It fades into, to some extent, anorexia. High intensity exercise. BMI may not be that low because of muscle being heavy. Psychological stress, chronic illness, and genetic factors. There's some overlap with congenital hypog. often resolve spontaneously, but it may take several years if it was severe enough for clinical review. So you're only seeing the selected cases. Treatments obviously reduce exercise and psychological interventions, but really do not pursue an exclusive behavioral approach for more than 6 to 12 months. And actually, if it's pretty obvious at the beginning that there's no realistic prospect for change, this is an athlete, start transdermal HRT straight away. Do not pursue an exclusive behavioral approach for months and months on end. Intervene early with HRT to protect bone and to protect sexual function. And this is something that other guidance has not yet said, hence the double asterisk. So what threshold for serum estradiol? Well, obviously, any threshold is meaningless without amenorrhea. Remember, you get the lab reports for estradiol levels, and it tells you level in early follicular, late follicular, mid-luteal. This is all rubbish because actually, why would you even be measuring estradiol level in someone with regular periods? So what is an abnormal estradiol level in someone who has prolonged amenorrhea? And our decision came to around 200 picomole per liter, which is about 55 of your American units. To be honest, we'd be also happy with 180 picomole per liter, which is 50 of your American units, just for a round number. And this really came from looking at what the levels were noted in women with hypothalamic amenorrhea and with lactational amenorrhea. So when are you going to measure an estradiol level in where you think you know the cause of amenorrhea? Well, you may suspect PCOS, you may have someone on progesterone contraceptives, or may have particularly someone on Depo-Provera. In polycystic ovary syndrome, if it's primary amenorrhea, you really want to do an estradiol level just to really make sure that this really is an estrogen deficiency. Similarly, if the endometrium is thin, that does not fit with PCOS, whatever the ovaries look like. And progesterone contraceptives, well, if the patient, they can shut down the female axis in certain cases. Not the Mirena, though, but the others, the systemic progestogens. And so if a woman says that she's got obvious amenorrhea due to contraception, but she's also got sexual symptoms, vaginal dryness, hot flushes, sweating, that is really worth checking estradiol level. And actually, Depo-Provera is so prone to shutting down the female axis that we recommend that the women should be asked routinely at annual review by the nurse that actually, have you got sexual symptoms? Have you got flushing? Have you got sweating? So treatment strategies. So replacement is with estradiol. We don't recommend horse estrogen, and we don't recommend combined pill as first line. If the uterus is intact, you need progesterone, either sequential, continuous, or via a coil. Use the lowest dose for protection, and we favor natural progesterone, so miraculized progesterone, or its stereoisomer dydrogesterone as the metabolically neutral. Although actually norethistherone, other than Mirena, offers the best endometrial protection. The aim is to relieve symptoms, achieve fertility, and fertility is a separate thing. So I won't go into egg donation for POI, but certainly for hypothalamic amenorrhea or congenital hypog or pituitary, the gynecologist will always try and sell your patients IVF. There is no need for that. All they need is natural cycle, low-dose gonadotropin, ovulation induction. And their cumulative rate of natural pregnancy is almost indistinguishable from that of a normally fertile couple. Monitoring HRT, we could agree on symptoms, we could agree on bone density. There was a split between the gynecologist and the endocrinologist on the panel. And so I would certainly recommend measuring estradiol level as part of your monitoring, but that wasn't mandated as part of the guidance. How long to keep on for? Well, at least till the median age of menopause. But remember that women will often have gaps in treatment, may have been diagnosed late. And so in that case, where there's lots and lots of missed years, we would recommend actually go on for rather longer, probably until the late 50s. And even after that, it may, if the bone density is poor or there's individual patient preference, they can continue for longer. The point is, we establish a date at which we want you to carry on until this date, this age. Then afterwards, okay, then it's up to you. We're not ordering you to stop, but actually neither are we really pressuring you to continue. So how does the pill look like compared to HRT? Well, combined pill, ethyl estradiol, synthetic estrogen, 21 days progesterone, 7-day gap, and then restart again, have your bleed during the gap. HRT, sequential, the estradiol is continuous, there is no gap, the progesterone is intermittent. 2 weeks on, 2 weeks off. You have your period just after stopping. Again, I'm sorry that these slides are not projecting properly. With continuous combined HRT, essentially the estradiol is continuous and the progesterone is also continuous, but it's spread more thinly, low dose spread more thinly. Or you can have the Mirena IUD. Different kinds of HRT, so the tablets, patches, sprays, gels, according to patient preference, although really in older women with vascular risk factors, but you really want to go for transdermal. Here are some rough dose equivalences. Remember that the preparations that we have available are those designed to shut down hot flashes in menopausal women. Therefore, the lower doses, really 3/5 patches or the 1 milligram or 0.5 oral, are unsuitable for young women. They're just simply not good enough. And actually, you may even need to use higher doses in young hypogonadal women, higher than the doses that are licensed. And here's the rough equivalences here. Progestogens, each have their different characteristics. Women vary their tolerance. Effectively, if a woman doesn't really like one form of HRT, basically you're looking at changing the progesterone. The estrogen is fixed. The estrogen is the same whether it goes transdermal or oral. Macroprogesterone or digestion, the stereoisomers, we like them because they're neutral lipids, best if you've got high lipids, can make you sleepy at night, so best to take them at night. Mirena's useful if you've got persistent systemic estrogen, like your body doesn't like progesterone, or very heavy withdrawal bleeds. And actually, every now and then we have a young girl, say Turner's or with educational difficulties, who finds kind of periods absolutely traumatic. And about once a year, we actually get a Mirena inserted on a general anesthetic in a young girl just to kind of close down the bleeding issue for the next 5 years. Your top choices, obviously products vary according to country, but certainly your dose of estradiol will be between 2 and 4 milligram tablets, and if it's a patch, about 75 to 200 microgram patches. You may need to apply more than one patch at the same time. Calcium vitamin D, well, yes, of course, these recommended intakes. Bone density. So if you've been in for longer than 6 months, we recommend a baseline DEXA scan. If the baseline DEXA scan was normal and you start HRT, there's no need to repeat for up to 10 years. However, if the baseline DEXA wasn't so good, we suggest repeating within 5 years, depending on other factors, such as particularly poor compliance or other bone factors or fractures. Migraine with aura in women under the age of 50 associated with an increased stroke risk, and therefore we recommend transdermal in these women. Remember that estrogen deprivation is not a treatment for migraines. And if you've got no aura, you can give any HRT, although we still suggest transdermal. Does it decrease breast cancer risk? Well, what you're doing is you're taking the risk back to that of a normal young woman. And so you're restoring the normal risk. This shouldn't be a pretty discussion that you have in a prolonged need with your patients. Just reassurance, really. Ever had breast cancer before? Can we ever give HRT? Well, almost never, really. Even if you're estrogen receptor negative, there's still a risk. Maybe, if you're triple negative, then you consider it after discussion with the oncologist. But importantly, everyone can have vaginal estrogen, particularly if they're on tamoxifen, even though some GPs and some oncologists can't quite get their heads around that. And of course, this is also good to prevent urogenital atrophy, and not just for sexual symptoms. But what about previous thrombosis? Or, well, you think about, well, what's a particular risk factor with the previous VTE? Anything that's changed since then? But essentially, with women who have a thrombosis, we don't treat them by bilateral oophorectomy or GnRH analog. And therefore, we wouldn't consider estrogen deprivation as a treatment for a hypogonadal woman without a VTE. You'll use transdermal. You may need to give a long-term rivaroxaban or other anticoagulant, but really, you're not going to be saying to a 30-year-old, actually, no HRT for you. Estradiol, of course, transdermal, and we recommend progesterone or Mirena or microprogesterone or dydrogesterone orally. Endometriosis or fibroids, benign gynecological conditions, well, you really want to use either Mirena IUD there or a continuous combined progestin. Cyclical HRT tends to promote growth of fibroids and tends to worsen endometriosis. And of course, the symptoms worsen, refer to gynecology. Contraception, of course, it's impossible if you've got Kalman syndrome, congenital hypertrypsin, or gonadal dysgenesis. But it's really possible if you have hypothalamic amenorrhea, or if, for instance, you've been treated for prolactinoma, or have had antidopaminergic drugs reduced, then you can fall pregnant really quickly. So in these situations, you think about what contraception you might advise. We obviously will rather like the Mirena coil if that is tolerated. Otherwise, you might consider a combined pill. However, we'd recommend one of those based on natural estradiol, like Clara or Zoeli, that are increasingly becoming available. Again, you can measure it. So I'm coming to my conclusions now, and I'm sorry about these slides not working, partly. So these are the really key takeaway points. An estradiol level below 200 picomole per liter, below 55 or below 50, your American units, where you got amenorrhea for longer than 6 months, relevant features are consistent with hypogonadism and should be investigated as such, even if you thought there was another cause for amenorrhea, such as you thought it was PCOS, you thought it was a progesteronic contraceptive. Doing it. It's really important to determine etiology, because that determines some of your management. And this is a great thing from Lisa Weber, one of the gynecologists at Imperial, said, there is no substitute for estradiol replacement, and there is no valid non-treatment strategy. Hypothalamic amenorrhea, do not mess around with lifestyle for longer than 6 to 12 months. It's important to give it a go, but beyond that, they need a transdermal HRT. And some of them will need it right from the beginning. If it's totally obvious, they're not going to change their eating pattern or their exercise pattern. Choose native estradiol over synthetic estrogens. There's no evidence that HT increased the risk of breast cancer in young women above being female. If there are thrombotic risk factors or even a history of thrombosis, transdermal HRT, estrogen deprivation should not be done. You may need to use higher doses in younger women than standard preparations. There's no sense that you can't go and have it for longer than 5 years. This is nonsense. You go up to the range of menopause or even a bit beyond. If you are going to measure an estradiol level, a reasonable target range would be 300 to 600, 350 to 500, according to either Turner guidelines or UK transgender guidelines. That would be a reasonable, sensible estradiol level to aim for. If you aim for a level, half your women will need higher doses than 100 microgram patches or 2 milligram oral. Mirena is great if you want contraception. Assess bone density. But if you're using a bone-specific drug, if you're using denosumab or alendronate in a young woman, you've seriously messed up. Estradiol reduces fracture risk, and that should be your treatment for low bone density or fracture risk or even second prevention. And you may need to actively support your patients to continue HRT because of lots of the pressures, all the nonsense they get from social media. And just to, I've highlighted in bold the imperial measured members of the guidelines team, and also some past mentors who were very wonderful for me. So again, I'm going to stop sharing now. And again, I'm sorry that the slides did not advance as they should have done.
Thank you so much. It's really clear, really excellent. And it's nice to hear it from the person who's written the guidelines. That's fantastic. So we've got time for a couple of questions, Dr. Quinton. The first one is about your views of estradiol and testosterone implants used by gynecologists in POI.
Don't.
Okay.
So estradiol implants don't. The transdermal oral work very well. Testosterone is not a form of HRT in a young woman. This is something for supplementing, presumed to supplement libido. If they want to get it by the gynecologist, that's fine. But the idea that it should be a first-line treatment, no.
And if they have high testosterone levels, how would you manage these patients?
I think it would be exceptionally unusual to find a woman who's hypogonadal with a high testosterone level. You'd question the diagnosis, to be honest.
What if they have an implant? Sorry. So
if they have an implant, well, you have to wait for the damn thing to wear off. Actually, obviously, gynecologists, they get paid money to put an implant in, so they are incentivized to do these things, but they don't make much sense.
Thanks.
Lots of my friends are gynecologists, have to say, but I do tease them.
So women with POI, what medication would you give to help induce ovulation and improve fertility?
POI, there's nothing you can do hormonally. The only option really is to keep your fingers crossed, and they could be the 1 in 20 who manages to ovulate in a brief period of remission. And for pregnant, there's nothing you can do. For central hypogonadism, hypothalamic amenorrhea, really great treatment, natural cycle, gonadotrophin, ovulation induction. You give me a low dose of FSH, just enough to pull out one big fat dominant follicle. Watch it grow, watch it grow, watch it grow. If you give too much, you get too many follicles. If you give too little, you won't pull one out. Once you've got a nice big fat mature dominant follicle, inject HCG, trigger ovulation, go home, have sex, get pregnant, job done. And then you can continue without, then the placenta make loads of estrogen during pregnancy, that's fine. And then when you deliver, the moment you deliver, you restart your HRT. Now, if you want to breastfeed, you want to start low dose estrogen only HRT. And then you can go back to your regular combined HRT when you've finished breastfeeding.
Thank you. And then one last question. What's the timing for measurement of estradiol, especially those on transdermal formulation?
It doesn't really matter too much, actually. It's a little bit different from the gels in men, where you really want to wait 6 to 12 hours to measure testosterone level. For women on patches or tablets or gels, the levels are actually pretty stable, actually. I've got no particular bee in my bonnet about timing.
Thank you very much again.
Oh, but watch out for skin contamination. Somebody puts on some gel over the venipuncture. If you see an estradiol level of, like, I don't know, 1,000, 2,000, that's someone who's got the estrogen gel over the venipuncture site. Or it's where a gynecologist has stuck in an insanely large dose of implant.
Thank you very much. I think in the interest of time, we'll move to the next speaker, but really grateful to Dr. Quinton for such a clear overview of the guidelines for female hypogonadism. The slides and the recording will be available on the Imperial Centre for Endocrinology website, so you can go back to them and look at the slides. Fantastic. Now, is Professor Comninos here? Yes, so it's my pleasure to invite Professor Alex Comninos, who's going to tell us a very interesting story for the latest treatments for menopausal hot flushes from bench to bedside. Over to you, Alex. Thanks.
Thank you very much, Professor Sam. Hopefully you can see my slides. I assume that's a yes.
Absolutely, thank you.
Yeah, okay. I'm just going to minimize this. Okay. So firstly, thank you very much, Professor Sam, for inviting me to give a talk this year at the Reproduction Masterclass. I think I did the Bone Masterclass last time. So I'd like to tell you a story about some work we did at Imperial. I hope you will enjoy the story, and I think there's a lot of luck involved and academic serendipity in this story. It's an important story. 6,000 women enter the menopause every year globally. So let's talk about Rachel. She's 51 years old. She has 10 hot flushes a day for the last 3 years. As a result, she wakes up sweating at night. She's tired and moody all day. She's unable to concentrate and so has to frequently pause her work. Now, how do we classify hot flushes? Well, we use the FDA hot flush classification table, which was published in 2003, and we have something similar in Europe. So basically, a mild hot flush is a heat sensation without sweating. Moderate is now when there's sweating, and severe is when it causes a cessation of activity. So Rachel has severe hot flushes because she both has sweating, which would take her into the moderate category, and severe, which because she needs to cease her activities. So what has Rachel tried? She's tried HRT, but got daily headaches. And she's tried other non-hormonal therapies like gabapentin and herbal remedies like black cohosh, but they haven't really helped her at all. So at this point, there are no real options for her. So let's talk about the menopause. So as you're well aware, this is the permanent cessation of menses due to loss of ovarian follicular activity. And this has physical, psychosocial, sexual, and overall impacts on well-being due to this drop in estrogen. And perhaps the most common and the most problematic of these symptoms are these menopausal hot flushes. Hot flushes affect up to 80% of menopausal women, with 20% of them describing them as severe, and at least half are moderate. They typically last for 4 to 10 years, and I think the median is around 7 years. So 7 years of hot flushes, with 20% describing them as severe. There are, of course, very good treatments, hormone replacement therapy, HRT, but with this comes an increased risk of breast and ovarian cancer, strokes, and blood clots. And so in some, HRT is contraindicated or relatively contraindicated. It's typically used for a limited duration, and frequently patients actually decline. They're not really keen on trying HRT. So what about alternatives? Well, there are some alternatives. I think paroxetine, low-dose paroxetine was the only other recently licensed medication for hot flushes by the FDA. But there's also clonidine, tibolone, and gabapentin have been used to some effect, but they're generally less effective and have side effects. So I think you'll agree we really need new effective treatments for menopausal hot flushes. It's a big problem. So how are we going to find new treatments? Well, we probably need to have a better understanding of the cause of these menopausal hot flushes. So let's go back in time to 2012 and some work we were doing at Imperial. We were looking at the neuropeptide, neurokinin B. It's encoded by the TAC3 gene. It is similar, well, it acts on the NK3 receptor, and it's encoded, as I said, by the TAC3 gene. So it's quite a small peptide, 10 amino acids. So by contrast, serotonin is several hundred amino acids. Kisspeptin is about 54, 10 to 54, depending on which version you use. So where is neurokinin made? Well, it's made in the hypothalamus. And this area in the hypothalamus also secretes kisspeptin and dynorphin. And so the neuronal population that secretes neurokinin B is also termed the KNDy neuronal population. K for kisspeptin, N for neurokinin B, and D for dynorphin. And these are located in the hypothalamus. What do these KNDy neurons do? Well, as you're probably aware, and hopefully aware, the KNDy neurons sit at the apex of the reproductive axis. I'm sure you all know that kisspeptin stimulates this downstream axis, GnRH, LH, and FSH, and going down to testosterone and estradiol. And these sex steroids exert their negative effect on the apex of the axis, not on GnRH, because GnRH neurons don't have the estrogen receptor, but it's on these KNDy neurons that you get the negative feedback in the reproductive axis. These KNDy neurons are where the estrogen receptor alpha is located. So KNDy neurons we know are important, or at least kisspeptin we know is important in stimulating the reproductive axis. Now, if we zoom further in on a single KNDy neuron within this hypothalamus, you can see it here. You can see the in pink, you can see neurokinin B being released, and it also has its own receptors for neurokinin B. And it's also got the intracytoplasmic receptor for estrogen, which exerts a negative effect typically. And the KNDy neuron projects to the GnRH neuron. We know that kisspeptin is released here and can stimulate downstream reproductive hormone pathways. But what we were interested in at that time, alongside our kisspeptin work, was what about neurokinin B? If you administer neurokinin B, does that also stimulate downstream reproductive hormones, similar to how kisspeptin does? So we conducted this work at Charing Cross Hospital in West London, and we have a research unit here on the 4th floor. It looks a bit like this, and this is actually the same bed where the first participant was administered neurokinin B, and we have an infusion pump, and we measure blood pressure and safety variables over there. So in this work that we did, you can see Chana Jayasena, Aquila de Silva, Ali Abbara, and Waljit Dilla, of course. We did all sorts of ways for giving neurokinin B. We did short infusions, long infusions, healthy men, healthy women in all phases of the follicular cycle, and we really didn't see any significant effect on downstream reproductive hormone secretion. But our study was limited slightly. So as you can see here, the answer was no, it doesn't stimulate reproductive hormones at the doses tested. But if you read the results section, we wrote here, at the dose of 10.24 nanomoles per kilo per hour, so that was the top dose that we trialed, 3 subjects, so this was 3 men, experienced a hot sensation and appeared flushed. Okay, so these are healthy young men being administered neurokinin B and experiencing intermittent flushing. And I remember calling Professor Diller at the time and saying, oh, I'm not sure, I think our neurokinin B might be contaminated. It doesn't make sense. Why are they getting hot flushes? We're looking at downstream reproductive hormones. And so we were slightly interested in what was going on at this time. If you want to experience a hot flush, if you're a man and want to experience a hot flush, then do let us know. We can give you a neurokinin B infusion. It is quite something. Now, around that time, we flew off to Tokyo for a kisspeptin meeting, and the wonderful Nomi Rance presented this work, where she basically showed that these KNDy neurons are also involved in the modulation of body temperature in rodents. And so we thought, perhaps, what about a role for these KNDy neurons in menopausal hot flushes? And so, like good scientists, we hit the literature, and we found this paper from back in 1991, in fact, that showed in postmenopausal women's hypothalamy, there is an increase in KNDy neuronal size, so double in size, and actually 15 times in number. So there's a vast increase in KNDy neuronal size and number post-menopause. And so we can add to this diagram that we're building up as we go along. that if you take away this estrogen, so similar to a postmenopausal woman, there is an increase in neuronal activity, in KNDy neuronal activity. Now, there was also literature showing that these KNDy neurons project to a key thermoregulatory brain center, namely the median preoptic nucleus. So this work showed basically in rodents that if you inject a NK3 agonist, senctide, directly into this thermoregulatory center, you get activation of the neurons as demonstrated by CFOS expression on the right panel, B. And this is timed together with a decrease in core body temperature. That's the black dots over here, because the tail vasodilates, which so there's heat effectors at play, and that causes a reduction in core body temperature. So we can add to our diagram here that these KNDy neurons communicate with these thermoregulatory neurons through neurokinin B. So there's NKB, well, the NK3R receptors on these thermoregulatory neurons, NKB released there, and it controls these thermoregulatory pathways. So far, I've shown you how our human participants got hot flushes when they were given NKB in our study. I've shown you how the NKB system has a role in temperature regulation in rodents. There's an increase in size and number of these neurokinin B neurons in the menopause. The neurokinin B system communicates with the key thermoregulatory brain center, the median preoptic nucleus. And I showed you in the end, the stimulation of that area results in tail vasodilation in rodents, so a hot flush. So we wondered, is KNDy signaling actually involved in a human body temperature? So the first thing we did is we asked that could neurokinin B administration to premenopausal women, so not postmenopausal women because they're having hot flushes anyway, to premenopausal women, could it trigger menopausal-like hot flushes? So here we recruited 10 participants, and they were administered a 30-minute infusion of either placebo or neurokinin B in a crossover study. They were obviously blinded. And as you can see here with the red dots symbolizing hot flushes and their duration, you can see that 8 out of the 10 volunteers reported hot flushes during their neurokinin B infusion, but none during their placebo infusion. And that 8 out of 10 is actually quite similar to the sort of 80% of women who experience hot flushes. So there might be something about the sensitivity to neurokinin B in 20% of the population that may have a reduced sensitivity and hence not flush. We also looked at heart rate during these hot flushes and saw typical elevations similar to normal hot flushes. Skin temperature also went up. We measured it using a skin temperature probe and thermal imaging, as you can see here. We also measured sweating. So this was measured using a skin conductance device that's placed over the sternum, and it measures the conductance between these two electrodes. So if there's moisture on the skin, there is better conductance. And we saw that there was increases in episodes of flushing as judged by the skin conductance. So this is an objective measure of hot flushes as opposed to a patient reporting a hot flush, which is a subjective measure of hot flushes. So could neurokinin B administration to premenopausal women trigger menopausal-like hot flushes? The answer was yes, and it's typical in location. I remember one participant saying, it feels like hot air is blowing on my face, which is often something that women who are experiencing these hot flushes report. They had associated symptoms and signs, and the duration was typical as well for menopausal hot flushes. So I think at this point we had a better understanding that these KNDy neurons were involved in the etiology of hot flushes. And so the next step, I think, was to take this into patients. What about blocking this system? If we blocked the KNDy neurons, could we stop hot flushes? So together with Walter and Channa, we applied to the MRC for a grant to basically block this neurokinin B system in postmenopausal women as a proof of concept study. Now, of course, we needed a drug that could block this system. Now, luckily, NK3 antagonists were at that time already available. How come they were already available? Well, they had been developed for schizophrenia. There was data showing that NK3 agonists, administered to rodents resulted in movements like tail whips and head twitches and four-paw treading, which is schizophrenia-like behaviors apparently in rodents. So there was a lot of excitement. This was back in 2005, that this may be the next generation of antipsychotics. Unfortunately, they didn't work in this 4-week clinical trial. You can see AZD2624, the first bar, was no better than the last bar placebo and far inferior to olanzapine in the CGI-I scale. So they were binned, they were put on the shelf. But we asked AstraZeneca, can we take this compound off your shelf and trial it in women with hot flushes? They said yes. And so we performed a randomized placebo-controlled double-blind 2-way crossover study in 30 healthy men, 30 healthy postmenopausal women who had 7 or more hot flushes per day before the study. It was a crossover study, so they had 4 weeks of the drug or 4 weeks of placebo, blinded, of course, throughout. And so our primary outcome was hot flush frequency, and we were quite enthralled with the 73% reduction in hot flush frequency from baseline. You can see placebo as well with a very strong reduction, and that's known in the literature that placebo works very well in hot flushes, and sometimes makes me think that I should be selling placebo and probably do well commercially then, and maybe some alternative medicines may be capitalizing on that placebo effect. In terms of secondary outcomes, the effect was very rapid, so within 3 days, and there were a lot of improvements in severity, bother, interference, psychosocial improvements in sleep. There were no serious adverse events, but one of the participants had quite a marked LFT rise. So this particular compound was not taken forward, but the class, the NK3 antagonist class, was developed further as a consequence of this work. So if we go back to our diagram, we can now add that these NK3R antagonists can basically block the communication between the KNDy neuron with thermoregulatory neuron, so less activity of the thermoregulatory neuron, and they can also decrease the activity itself of that KNDy neuron, so like a dual mode of action. So if we look at the timeline of development of the NK3 antagonist, you can see in 1991, that was the first paper showing that hypertrophy of those neurokinin B neurons in the postmenopausal woman. There was a study for schizophrenia using this compound in 2004. Evidence in 2011 that the system was involved in thermoregulation in rodents. Then we moved to the translational research. So the studies were performed with neurokinin B and then blocking the system with the AZD compound. And then I was delighted that essentially this was taken forward with the final approvals of a different compound, Fezolinetant, an alternative NK3 antagonist, which was FDA and MHRA approved in 2023. And I think there's several 100,000 women on it globally at the moment. So Fezolinetant, a little bit about it. This is sort of the pivotal papers on which the approvals were made. That you can see this is a graph of the frequency of hot flushes at baseline, and then you can see in the although placebo had a good effect, that's the top line here. Fezolinetant had a more dramatic effect. All the placebos then switched to Fezolinetant for the duration of the study, so you can see a long-lasting effect there. N numbers between 150 and 200 per group. Also, the severity of any remaining hot flushes also follows a similar pattern. You can see down to there. Now, a recent study, which is probably quite useful in terms of how one can use Elinzanetant, came out towards the end of last year. So here they actually just targeted women where it was considered unsuitable for them to have HRT, okay? Because HRT probably is the superior overall treatment. It can cover a lot of other symptoms related to the menopause. So here they're targeting women where HRT is unsuitable. So if you actually look what this group was made up of, it was contraindicated. It was use HRT with caution, women who had stopped HRT for various reasons, and actually quite a lot of women where they were averse to HRT. And what did they find? Well, essentially, there was a dramatic drop in frequency, 77% here versus 58%. Well, again, a very strong placebo effect. And again, the effect was sustained throughout the 24 weeks of this study. So how does Elinzanetant compare to our current treatments? Well, probably in a similar ballpark. This was some data just looking at different studies that have been published to date, but actually quite helpfully recently there's been another meta-analysis. It's basically looked at these treatments. So Elinzanetant is at the top two versus all these HRTs, and at the bottom SSRIs and gabapentin. And you can see Elinzanetant basically is in a similar ballpark to HRT. Then on the right side, you can see difference versus Elinzanetant. So the reference is Elinzanetant, so the straight line is where Elinzanetant sits, and so there's nothing that is particularly superior. There are treatments that are worse, which is the ones to the right, that's paroxetine and the SSRIs and gabapentin. So quite an impressive performance. In terms of side effects, there has been a signal with an increase in liver function tests. Maybe there, but overall, about 98% of women have no problems at all with liver function. And this has sort of recently led to some further changes in the frequency of recommended LFT monitoring. It's now 0, 1, 2, 3 months in the UK. This just was changed in January 2025 following a case of mixed cholestatic hepatic side effects from the Elinzanetant. Not too dissimilar. I mean, don't forget when you do statins, the BNF recommends 0, 3, and 12 months frequently with statins. In terms of endometrial hyperplasia, again, there was a slightly increased signal, but this has been discounted in later studies and also by the FDA for various reasons. It happened too quickly in the cases, and there's very heterogeneous cell types as well. But we still should continue to keep an eye on this. What about the future? So if we look at the bottom, Elinzanetant is on the horizon. Now, what about Elinzanetant? Well, it's actually an NK1 as well as NK3 receptor antagonist. What might be the benefits of NK1 receptor antagonism? Well, potentially on sleep. We know that an NK1 receptor antagonist can improve sleep maintenance in primary insomnia. And just to quickly go through the comparisons of these two drugs from this useful meta-analysis published recently, Elinzanetant versus Elinzanetant. In terms of hot flush frequency, you can see overall, fairly similar. They're both quite similarly placed to the dotted line. It's the 45 milligram dose of Elinzanetant that we use at the moment. In terms of hot flush severity, again, fairly similar. Elinzanetant does tend to be more towards the right in this meta-analysis. In terms of the sleep, where Elinzanetant may excel because of the added benefit on NK1, they use this PROMIS questionnaire. Essentially, they show a significant drop. So anything more than 7.8 is clinically significant. So there is a benefit in sleep. In terms of quality of life, they use the menopause-specific quality of life scale. Again, anything more than about 0.9 is meant to be significant on this scale. Again, significant clinical improvements. So the sleep disturbance, you can see Elinzanetant far to the right here in comparison to Fezolinetant. So there might be some added benefits of Elinzanetant in terms of sleep disturbance in the menopause. In terms of menqual in general, it's about the same with Fezolinetant. In terms of safety, it all looks fairly safe, but this is data only up to 26 weeks. We don't have the full 52-week data yet. In terms of side effects from this meta-analysis, again, fairly similar between the two compounds. In terms of other uses, so there has been some work on using NK3 antagonists in PCOS. This is a paper, it's a while ago now, 2016, did show biochemical improvements, but the effects were wearing off by day 28. And with Fezolinetant, has also been trialed, and again, there were biochemical improvements, quite dramatic biochemical improvements if you look at these numbers here, but there were no effects on endometrial thickness or menses. Maybe longer trials are needed. This was just 12 weeks. So quickly, if we just go back to Rachel, 51 years old, no options. You know, I think we hope that NK3 antagonists now offer an option to millions of women around the world. So finally, I would like to thank all members of the team, of course, Professor Walter Dillo, Ali Abbara, Akila De Silva, Sophie Clark, Chana Jaisena, Julia Prague, Rachel Roberts, of course, the participants, and our funding. Thank you very much for the opportunity to speak today. Thank you.
Thank you. That was a fascinating story. And thank you for talking us through the journey of the first observation of the flushing to the drug that is now in clinical practice. So there is a question about the NICE position on this, Alex. So
the preliminary decision, which is now going out for it's a draft consultation, the NICE have declined it, but I think it's basically they need more data to further. This frequently happens with NICE approvals, so I think with time, once more data has come out, this BMJ paper as well, which has some more data, might be helpful.
Thank you. So it's not available currently.
It's not available. No, it is available privately in the UK and being used, as I said, by hundreds of thousands of women. But it costs £44, I think, a month is the current price. It's much more expensive in the US. Also, I guess we've got tariffs and things to think of now as well.
Fantastic. Thank you very much. And meanwhile, Dr. Quinton's very kindly responding to your questions in the chat. So please keep an eye on the responses, which are very helpful. Okay. It's now 4 p.m. in the UK and 7 p.m. in Abu Dhabi. Thank you so much, Alex. Again, that was very, very interesting. We're going to move to the third talk, which is on androgen abuse by Dr. Bonny Grant. Bonny, thank you very much.
Thank you. Let me... So thank you, Professor Sam, for the opportunity to talk about androgen abuse this afternoon, this evening. So this is a largely guideline-free area at the moment. Yeah, I'm sure more and more people in the audience are coming across men who have a history or are currently abusing androgens. So I'm going to just go through what the risks are and kind of talk about some of the key studies that have been done that will hopefully give some statistics and some answers to some of the questions, so that you can take this forward with the patients that you see. So just to give some context of what we're talking about, so androgen abuse is the use of androgens without a prescription and for non-medical purposes. Okay, and I'm using the term androgen rather than anabolic androgenic steroid or anabolic steroids, as some of the substances that are being used are actually not steroids, and as all of them act via the androgen receptor, it's sort of felt that the correct term to use is androgens rather than anabolic steroids, but they're the same thing. So just to sort of see the spectrum of androgen use and abuse. So at the left side here, so testosterone replacement therapy for organic hypogonadism. There's no question or uncertainty here. This is a very clear condition in which testosterone should be given and is life-changing for men. In the middle, we've got these kind of functional hypogonadism or age-related hypogonadism, where there's perhaps a bit more controversy about which men should be given testosterone, and a lot of this is reversible if the underlying cause is looked at. And at the very extreme is androgen abuse. So there is no medical indication for this. These are men who have otherwise normal hypogonadal axis, they have normal testosterone levels, but they are choosing to use androgens for other means. And this is often linked with increasing testosterone doses. And these are the men and the conditions that I'm going to talk about today and what the studies are looking at. So the statistics that I'll use and the risks do not relate to TRT for organic hypogonadism or functional age-related hypogonadism. So how big of a problem is it? So there was this really good meta-analysis and meta-regression analysis done about a decade ago now in 2014, where they took lots of studies from all over the world to give an estimate of the prevalence. And it was calculated that the lifetime prevalence in men was about 6.4% and about 1.6% in women. Now, my feeling is that this has probably increased over the last 10 years, and I suspect that the numbers are actually higher than this now. I'm going to kind of focus talking about men, but there are women that use it, and the data around this is really, really sparse. But when we look at specific groups, actually the prevalence rate can really rapidly increase. So in non-elite sports, so these are your men who will go to the gym at the weekends, they kind of maybe do recreational sports. It's about 1 in 5 men that are abusing androgens. And I think most worryingly, high school students, 2% of those are using. There also appears to be a geographical difference as well. So in the Middle East, where many of our colleagues joining today are, much, much higher rates of prevalence, whereas in North America and Europe, it's much more around sort of 3 to 4%. So in specific pockets of people, you will find that it's much, much more prevalent, and that's something to be aware of. So anyone that's come across a man who is abusing androgens will often find that they come with long reams of paper of the different regimes that they're on and will claim that the androgens have different effects. And it can often be quite overwhelming and confusing. So I've tried to sort of simplify it today. The main thing that you need to determine is whether what they're using falls into these one of 3 categories in the first 3 columns here. So the testosterone esters are quite straightforward. So these are your testosterone enanthates, libidos, the sort of straightforward ones that many of us will use in clinical practice. The second group to be aware of is the 17 alpha alkylated androgens. And these are important as these are the ones that are taken orally. And these are the ones that have a high potential for liver dysfunction and hepatotoxicity. And this is due to first pass metabolism. So these are the ones that you need to be really aware of liver problems and the risk of hepatotoxicity. And then the third group is these 19 nortestosterone derivatives, the most common being nandrolone or trembolone. And the names in the brackets that I've given there are kind of the street names that men might use. And these are important because these can have particularly progestogenic effects.
Not yet, no.
Progestogenic effects such as
Yeah.
weight gain and gynecomastia. And then I've just listed some of the other image and performance enhancing drugs that men will often use alongside. So I'm sure many of these are recognizable that we use in clinical practice all the time. So things like thyroid hormones, cabergoline, growth hormone, and then some other drugs which I'll come on to mention, which are used to try and mitigate against the adverse effects of abusing androgens. So there can be really complex, detailed regimes that the men will come with. But if you break it down into these 3 groups, that will sort of help simplify what you need to look out for and also what the associated effects with them are. So these are kind of the androgens that are commonly used in a study that we're currently running. So the most common is a testosterone enanthate with an average dose of sort of 425 milligrams weekly. So if we compare that to clinical use, where it's about 250 milligrams every 2 to 4 weeks, you can see the sort of magnitude of use there. Drostanolone is one of the oral androgens that are used, and this doesn't have a license in humans at all, but this is commonly used. Oxandrolone is another oral drug which doesn't have a license in the UK for use in adults, but is sometimes used in children with short stature. And just to kind of give some context, the dose used in children is about 17.5 milligrams per week. So these men are using 320 milligrams per week. And then Trenbolone, which again has no license in humans, in fact, has never been tested in humans, and is only used in veterinary medicine to increase the profits in livestock. And the men are using similar doses to what is used to breed livestock. So just to give you some context of the levels there. So why are the men using it? So if we think back to the 1980s, the abuse of androgens was seen to be a very underground community, and it was men who were using it for bodybuilding competitions. But as we've sort of gone through the last few decades, and I think with the increase of social media, it's now much more used as aesthetic motivations. So men are using it to improve their physical appearance and to gain muscle, to improve their strength, and also issues around sort of self-esteem and body image, and the sort of old ideas of it being bodybuilders or kind of those groups of men is only about 15% now. It's much more your men in the general population who are concerned about their sort of confidence and self-esteem. And it's men who are often starting between the ages of 18 to 30 and will often find that they then continue much later into life as well. So here are some risk factors that have been shown to be associated with androgen abuse in the future. And you'll see that a lot of these will overlap with risk factors for kind of other substance misuse. So childhood, physical and mental abuse, other substances, inadequate housing, and sort of pre-existing eating disorders or sort of body image disorders, particularly this idea of looking small or looking very or lacking in musculature. Will predispose men to wanting to abuse androgens in the future. So what are the clinical clues that may, if you see a man, may sort of make you suspect that he is abusing androgens? Well, the obvious thing is a very muscular gentleman. But you may see some gynecomastia, and this happens because the testosterones and the androgens are aromatase to estrogens, and it's the estrogens that then drive the development of breast tissue. So if you're seeing gynecomastia in an otherwise very muscular gentleman, this could be a clue. Some men will get tendon ruptures, so this is showing a bicep tendon rupture just here, or they may have scars to suggest previous tendon rupture repair. Truncal acne in men who, beyond the normal age for acne is very typical of androgen use. There may be abscesses, particularly over certain muscles. So there's a belief in this community that the drugs will work better if they're injected directly into the muscle that you want them to grow. Obviously, as we know, the androgens will go all around the body, so that's not the case. But so you may find abscesses developing over the biceps or the deltoid muscles. And you may see striae, particularly over the biceps or deltoid, suggestive of this rapid muscle growth. How about biochemical clues? So I'll kind of go through some of these. So this is some of the things you may see during use. So testosterone classically will be very high. So you may see in the levels of sort of 80, 90, 100 nanomoles per litre if they're using those testosterone esters. But don't be fooled if you see a low testosterone level. And this is because some of the substances, particularly in the other groups, will not be picked up by the assay. So you may actually have a low testosterone level on your assay, even though the body's androgen exposure is actually very, very high. LH and FSH will always be suppressed as a result of the exogenous androgens. Estradiol may be high or no change, so high if the androgens are aromatase. SHBG will be low due to the high levels of androgen. Hemoglobin and hematocrit will be high due to the androgenic effect on the bone marrow, causing an increase in hematocrit. But again, if everything else is pointing towards it, don't be fooled if these are normal, as some men will go through sort of venipuncture in order to minimize the risk of high hematocrit, and so will take off a unit of blood every couple of months. So this can be normal. Lipid effects, most commonly, you'll see a reduction in HDL cholesterol with an increase in LDL, so your total cholesterol may be unaffected. And ALT may be high if the men are using the oral androgens, but also you can sometimes get a transient rise in ALT due to recent exercise. So if it's mildly raised and you're not sure, you can ask them if they can abstain from exercise for a few days and recheck. So there's a very good study done by Shankara Narayana, and the team in Australia, and they looked at 90 men who were currently using or had stopped or had never used, and they found that a single suppressed serum LH was the best at differentiating between current users and those denying current use, with an accuracy of 89%. So this seems to be the serum biochemical marker that is most accurate at detecting between current and non-use. So what are the adverse effects of androgen abuse? So the abuse of androgens is associated with a 3 times higher mortality compared to men who don't use. So this is a really, really serious thing. I've sort of highlighted some of the common adverse effects here. Mood disorders are an interesting one. So there seems to be a sort of bidirectional relationship between androgen abuse and mood disorders, whereby a pre-existing mood disorder may put you at risk of using in the future. But also there are studies that suggest that psychosis, mania are increased during these supraphysiological levels of androgen abuse. And then after cessation, there can also be new mood disorders, such as depression and anxiety, that develop with cessation. Erythrocytosis and sort of cholesterol levels I've touched on. Cardiac hypertrophy, so particularly left ventricular hypertrophy, can happen, and this is normally reversible. So if this is picked up, the men can be reassured that this will normally reverse if stopped. Hypertension, again, may be due to fluid retention based on which androgens they're using. And the blood pressure normally increases by about 10 to 15 millimeters of mercury, both systolic and diastolic. Bloodborne viruses, so as a result of needle sharing or poor injection techniques. And I think most interesting to sort of the audience here, erectile dysfunction and infertility. So why does this happen? So we've sort of already seen this image. So we've been thinking about the male reproductive axis. So under the influence of GnRH and kisspeptin, as we know, the pituitary will release LH and FSH, acting on the Sertoli cells to produce sperm, or on the Leydig cells to produce testosterone and a small amount of estrogen as well. And then there is negative feedback on the pituitary and the hypothalamus, downregulating this system. So as an exogenous androgen, this system will be shut off. So the hypothalamus and the pituitary will stop making LH and FSH, and then you will stop making endogenous testosterone and stop making sperm. However, when the androgen abuse is stopped, this system doesn't immediately wake up, very similar to if you take exogenous corticosteroids, the adrenal glands will not immediately wake up. And men will often during this time report a low libido, erectile dysfunction, low mood, low energy, and will often restart use and develop a dependence. So it's estimated that around 30% of men will go on to develop a dependency syndrome to androgens and be unable to stop. And I think about 65% of men, when they stop, will restart within the year following cessation, often due to these symptoms. So there are some things that the men try and do to wake up the hypothalamic pituitary gonadal axis quicker or to kind of mitigate against these symptoms. And these are a group of drugs that are known colloquially as post-cycle therapy. And this will often include selective estrogen receptor modulators, SERMs, such as tamoxifen and clomiphene, or aromatase inhibitors, such as anastrozole, and also human chorionic gonadotrophin, or HCG. And the way that these work, so the SERMs and aromatase inhibitors will reduce the negative estrogenic feedback on the hypothalamus and pituitary to therefore stimulate the release of FSH and LH and indirectly stimulate endogenous testosterone. Whereas HCG is a very similar molecule to LH and will act directly on the Leydig cells to stimulate endogenous testosterone. But I just want to make this very, very clear that the use of these drugs in this situation, so in men who have been abusing androgens, it is unproven and it actually might prolong testicular recovery. So these men do not have an underlying issue with their HPG axis. So with enough time, it will wake up. So by giving them these drugs, it may just be slowing down that ultimate recovery process. So when we're thinking about men and whether they're likely to stop, we did this survey, was published 2 years ago now, where we asked them how likely it is that they are to stop in the next 5 years. And rather disappointingly, only 25% said that it was likely or very unlikely they would stop. So most men are not thinking about stopping. And the common reasons that they cite for not wanting to stop is concern over their loss of muscle, concern over good quality information from health services and supportive care, and actually really worried about their testosterone levels and whether their testosterone levels are going to recover. So what can we advise these men on how long it will take for their testosterone levels to recover? There's been a couple of really nice studies that have looked at this, which I'll just go through. So the first one is the same team I mentioned earlier from Australia. And what they did is they took 90 men into 3 groups of current users, past users, and non-users. And they took the average of each of these parameters for the non-users, so in the green. So if we look at the serum FSH up on the top right, so they took the average of all of these, and then they did a linear regression of the current and past users against time, and then basically looked how long it would take for this group to reach the average of the non-users. And they did that for semen parameters and also some of the biochemical parameters. And what they found was that for the sperm concentration, it will sort of recover within around 10 months, a little bit longer for things like sperm output and sperm motility. For LH, it was also around 10 months, for FSH, just over 18 months, and sort of even longer for inhibin. And what they found is that age, usage patterns, so whether the men
But does it still hurt?
used continuously or whether there was kind of stops in between, had no significant impact on the rate of recovery, and neither did post-cycle therapy, so these SERMs and HCG drugs. There was then another study, so a prospective study that was done by Smit et al. In the Netherlands, and they took 100 men who were planning to start a cycle, and they did baseline measurements. They then took measurements during use, 3 months after stopping and 12 months after stopping. And this was good because they were able to compare values within an individual as opposed to the previous study where it was a cross-sectional one. So if we first of all look at LH and total testosterone, so this was them at baseline before a cycle of androgen use. And as you can see, during use, LH is completely suppressed, and the mean total testosterone got up to 80 nanomoles in this group. And at 3 months after cessation, there was no significant difference between the LH and the testosterone levels, suggesting that these parameters had completely returned to baseline within 3 months. FSH, there was no significant difference at 12 months, so this took a little bit longer, sort of reflecting what the previous study found as well. And total sperm count, so it was a little bit after 12 months before there was no significant difference between the two. And they also similarly found that the use of post-cycle therapy was not associated with testosterone levels. However, these drugs were used in over 80% of the men. So they had very, very few men who were actually not using SERMs and HCG. And then we published this study at the end of 2023. So we were interested in, is there anything that can predict who is likely to recover and who isn't likely to recover? So we took just over 600 men who were attending a addiction clinic specific for men abusing androgens in Glasgow, Scotland, in the UK. And we looked at lots of factors. And what we found was the men who were not using post-psychotherapy but had stopped more than 3 months ago were 6 times more likely to recover. And I've put the odd ratios and the 95% confidence intervals there for anybody that's interested. They were 4 times less likely to recover if they were abusing 4 or more androgens in one go compared to just 1. They were 3 times less likely to recover if they had been using for more than 6 months in total compared to those less than 3 months. And interestingly, we actually found that men who were using post-cycle therapy but had stopped less than 3 months ago, they were 4 times more likely to recover. So we did find that the use of HCG and SERMs did seem to affect recovery, but only if they were used sort of immediately after cessation. Later on down the cessation route, it didn't seem to have an effect. And actually, that's when time just became the most important thing. So I think when it comes to talking about biochemical and semen recovery with men and patients, I think this is kind of what you can say to them. It will take around 3 to 12 months for testosterone and LH levels to return to normal, and it will take a little bit longer, about 12 to 18 months, before FSH and semen parameters return to normal. And it's much more likely if you're using fewer androgens, so if you're just using 1 compared to 3 or 4 or 5, if you've been using for a shorter time period, and if the longer that you stay off them, the more likely you are to recover. This question about sort of post-psychotherapy, HCG and SERMs, I think is still to be determined, and there are no good quality randomized controlled trials that have been done to look at these drugs. But I'm sure many in the audience have, if you've looked after these men, will find that even though their testosterone levels will have returned to normal, many of them are still reporting symptoms which may be consistent with hypogonadism. So these studies here and some work that we're currently doing looking at withdrawal symptoms has shown that there is reduced quality of life scores, there is ongoing erectile dysfunction, reduced libido and depression, and this could be 2.5 years after cessation. The role of testosterone is conflicting. So there's not been consistent data coming out that these withdrawal symptoms are associated with testosterone levels. So there will be men who have seemingly normal or high testosterone levels who still have a lot of symptoms, and equally men who have low testosterone levels but do not seem to have a significant symptom burden. So it may be that there is something else in these men that is causing these symptoms, the severity of symptoms, and we're looking into that at the moment. And pre-existing psychiatric diagnosis seems to be a really, really strong predictor of worse withdrawal symptoms when stopping. So what can be done in terms of management? So as I've sort of said, there's currently no evidence-based treatment for androgen abuse cessation. So it's not like sort of opioid addiction and heroin addiction, where there's some quite nice pharmacological guidelines out there. So the things that I think need to be considered are, what are they at risk of from currently using? So what adverse effects are they exhibiting? Do they have increased blood pressure? Is there evidence of cardiac hypertrophy? Really importantly, what are they worried about? And do they actually want to stop using? So are they coming to you because they do want to stop, or are they coming to you because they actually want a medical prescription of testosterone? And it's really important to sort of discuss that with the men. And also, what are the other non-androgen risks from androgen abuse. So are they at risk of other substance misuse? Are they at risk of bloodborne viruses? And directing them to other substance sort of services maybe of use. And these are the sort of things that I think at the moment we can sort of try to deploy. So reassurance and monitoring. So this is going to be very resource dependent, but if you can engage someone in perhaps coming for regular blood tests to sort of show that their levels are improving and reassure them that they will eventually reach that point. Psychological support, I think, cannot be emphasized enough, and it really needs to be something that is focused on body dysmorphia. So these men will lose muscle bulk. It is impossible for them to maintain the level of muscle bulk off androgens because it is just not possible with endogenous testosterone production. So they need to be aware of this, and they need to sort of predict that this is going to happen. Because otherwise it's likely this is going to directly contribute to their low mood, and it's just going to increase the risk that they then relapse and start reusing. I've sort of said other substance abuse treatments where necessary, and monitoring of adverse effects where possible. Pharmacological, so nothing has been looked at and has been approved, but testosterone tapering regimes are sometimes mentioned, as I've sort of said, the use of SERMs and HCGs. The problem is these may just further prolong HPG axis recovery. So obviously, if you are giving somebody testosterone as a tapering regime, you are continuing the suppression of their axis. But it may be that these are looked at in the future, and it may be that as part of a pharmacological and psychological intervention that they do have use. So just in summary, so androgen abuse is increasing worldwide, and I'm sure we're going to be seeing more and more men with this history. LH is the best discriminator for current use. It is associated with a threefold higher mortality rate. We can sort of say to the men that their testosterone levels are likely to recover within 3 to 12 months and SEMA within 12 to 18 months. And symptoms may persist, but this may not be testosterone driven. The need for psychological intervention is really, really key, and we are desperate, and we are working on some good quality randomized controlled trials and hopefully some good guidelines in the future. Thank you very much.
One question is that have you ever prescribed HCG or SERM in your practice?
So it has been prescribed. I think the time when it's been used is in men who are looking for fertility, and perhaps where that 12 to 18 months, perhaps on the basis of the age of their partner, is just too long to wait. So it's a very individual, patient by patient thing, but I wouldn't advocate the use in sort of just general management of these. But in those specific instances, it may be useful.
Fantastic. Thank you very much. Okay, it's my pleasure to introduce our next speaker, Dr. Ali Abbara, who's going to talk about obesity and hypogonadism. But before Dr. Abbara shares his slides, remember at the end of his slides, there'll be a slide showing a QR code and link that you can use to complete a very quick feedback form and get your certificates for your appraisals, the CME, or the CPD on it. So all you have to do is to make sure you spell your name correctly on that, and then it'll be emailed to you immediately within a few seconds. Great, we can see your slides, Ali. That's fantastic.
Okay, thank you very much. Thank you very much, Professor Sam, for the invitation to speak. So I'm going to speak to you today about obesity and reproductive health, and I'm going to probably focus on male reproductive health just out of the interest of time. So we're going to start with a case, and I'd love to hear your feedback in the chat in terms of what you would do yourself. So this is a 45-year-old man who presents with fatigue and low libido. He's got no significant past medical history or medications, and he has a 9 AM testosterone of 13. So would anybody in the chat, if you let me know your thoughts, would anybody consider doing any further tests, or would you at this point discharge, reassure him that there's no evidence of hypogonadism, and time to go home? Okay, so do put in the chat what you would think to do. Good suggestion about free testosterone, check SHBG, discharge. Okay. Now let's say it was the same scenario, but his testosterone at 10 a.m. was 5 nanomoles per liter. Would anybody do no further tests, or would anybody, think this is unequivocal hypogonadism and he must have testosterone treatment? How would you view this different level? Would anybody not be happy to treat him? Okay, good. And somebody mentioned about gonadotrophins. So how would that influence your thinking? If the LH was 4 or if it was 10, would that influence how you would view that blood test? Okay, and then finally, what if he had a raised BMI? So he's got a low testosterone. Would you be happy to, so if you haven't found anything else, would you be happy to ascribe his hypogonadism due to obesity? Okay, so there's lots of very appropriate suggestions about checking a free testosterone. So we'll come on to that shortly. Okay, so I think we're all comfortable with the idea that luteinizing hormone is a pulsatile hormone, and a single test is not necessarily going to tell you a sort of accurate level. There will be variation depending on which bit of that pulse that you've caught. But I think we're sort of less sort of familiar with the fact that testosterone can also be highly pulsatile. So as part of our research, we do a lot of profiles of reproductive hormones where we measure them every 10 minutes or so. And it's important to recognize, even just within a short sort of 15-minute gap, you can have a massive difference in the testosterone level that you see. So we spend a lot of time in our sort of post-clinic meetings discussing, is it 14, is it 13, is it 15? I think we just have to bear in mind that it can be highly variable. And this is also a real plot of a real patient. So you can see that his very first testosterone level is 14 or so. And I think most of us would say hypogonadism excluded, unlikely to be the cause of his symptoms, even though if we did it slightly later in an hour, sort of 45 minutes after that first one, we would say it's highly likely. So you'd have a testosterone of 5, and he spends most of his day actually with a really low testosterone. And I think it's conceptually interesting in terms of endocrinology generally that we would sort of try and find the highest possible test and then say that your symptoms can't possibly be explained by the hormone level, even though he spends most of his day with a lower hormone level. So I think we did do this paper where we looked at what is the variation in hormone levels. So for the first, single blood test compared to the levels throughout the day. So as you'd imagine, luteinizing hormone is quite variable. So 28% is the coefficient of variation. Testosterone is actually slightly less variable. So this is during the day. So it does vary, but it will vary around a mean. And FSH was the least variable of the hormones. So this is within a single 8-hour profile. I think also it's sort of conceptually interesting to just understand that the reference range that we have for testosterone is a sort of population reference range. So it's what's normal for the population. But for an individual, they're likely to be much more around a particular part of that reference range. And so let's say, for example, this is a hypothetical, if somebody were to have testosterones around the upper part of that reference range for most of their life, and they were to get a relative hypogonadism, so not enough to have no testosterone whatsoever, they could lose quite a bit of their testosterone and still be within the reference range. But generally, we would say that it's unlikely, if they're within the reference range, that their symptoms could be explained by that testosterone. And it's interesting, in the EMAS study, 1/4 of the men with normal testosterone reported symptoms of hypogonadism. And that's usually suggested to indicate that the symptoms are not very specific, as opposed to there's a possibility that you could get symptoms within the reference range. And so this is another sort of similar study where they looked at the variability of testosterone levels over a period of months. So they looked at 9 blood samples over 3 months. And in that study, the coefficient of variation was 29%. And I think we've got some similar data, about sort of 40% in our data. So that's obviously why they ask you to measure the testosterone on more than one occasion, because obviously you can get fluctuations and it can just normalize on the next test. As we're all aware, testosterone has a diurnal variation. So this was the drop in testosterone from 9 a.m. to 5 p.m. It wasn't huge. It was only about 10% on average, but within that, there are some people where it drops more. And the 5 p.m. testosterone did correlate with the 9 a.m. testosterone on the graph on the right. So you can pretty much make an estimate of what the 9 a.m. testosterone might have been, but obviously you'd want to repeat it to just confirm. I think we're also conscious of the fact that there was a famous study by Coronia where they showed that after an oral glucose tolerance test, testosterone drops. But it's not just sugar, it's any kind of meals. And this is actually a mixed meal test seemed to drop the testosterone the most. So 34% fall in testosterone. Okay, so in terms of the guidelines, I'm sure you're all very familiar. You would measure it, repeat it if it is low to confirm that it is abnormal. Check SHBG if there's a possibility that that's abnormal. And obviously, if we're talking about obesity, that would be a situation to check SHBG. And then check for symptoms. Obviously, it can be sexual, physical, and then they also mention body composition. So obviously, obesity can affect SHBG, and as we know, only a small portion of the total testosterone is actually free and active. So the portion that's bound to SHBG is so strongly bound that it can't have an action, and if there is a change in SHBG, that will affect the free testosterone. And so this is a graph of SHBG and BMI. You can see that it falls very rapidly and at quite low BMIs. So especially at low BMIs, so 30 to 40, you want to calculate the free testosterone, which might still be normal in that range. And there's these obviously free calculators available to help you do that. Okay, so traditionally, with the EMAS study, there was this concept of testosterone dropping by 1% a year after the age of 40. And this was some more recent data that actually some of that could be explained by obesity. So in the absence, so this was a cohort with less obese people, testosterone is relatively flat until slightly older ages. So here you can see it's dropping from sort of age of 70. And at that point, the LH starts to go up. So that's suggesting this is a primary hypogonadism causing that dysfunction. And you can see also with obesity, there's a sort of fall in the total testosterone. So there was this idea that perhaps some of what we describe as late onset hypogonadism is actually obesity-related hypogonadism. One of the things that you can see from this graph that differentiates the two is that SHBG increases with age, whereas it falls with BMI. So when it falls with BMI, you get relatively more of the free testosterone still available. And so therefore you preserve your free testosterone for slightly longer. It's also worth noting that it falls pretty rapidly at the lower BMI. So beyond 30, it doesn't fall quite as much. And it's really in those sort of lower BMIs that it's really falling. But all the same, important to check the free testosterone. In terms of what sort of testosterone is abnormal, so this is again from the same study by Yeep. In terms of all-cause mortality, it starts to cross the threshold at testosterone's less than 10 and becomes significant at less than 7.4. It's also worth considering that obesity and hypogonadism is bidirectional. So obesity can cause hypogonadism, but also low testosterone can predispose to obesity. So this is some unpublished data, still collecting, but essentially showing This is fasting testosterone levels done at 9 a.m. And you can see it rapidly decreases with BMI. If you do the calculated free testosterone, it's obviously less of a fall. Worth mentioning, obviously testosterone can stimulate the hematocrit, but it can also stimulate lots of proteins, and that includes albumin. So there is a correlation between albumin and testosterone. So if you have somebody with hypogonadism, the albumin can also be lower, and that's going to be important for when you do your calculated free testosterone. So it is worth measuring the albumin rather than guesstimating it. And likewise with BMI, but obviously that could just still reflect the hypogonadism. So there was this really nice study where they directly measured free testosterone. So rather than calculating it, they used equilibrium dialysis to directly measure it. And you can see this is the range of free testosterone. They've used the 2.5 to 97.5 centile as the reference range. So this is healthy, non-obese men of all different ages. And then overall, the reference range is 229 to 1072. If they focus just on young men under 40, the lower limit of the reference range is 415. So you can see it's almost halving as you get to older ages. So how common is it, and how specific are the symptoms? So this is 100 consecutive men referred for bariatric surgery. 44% had a reduction in their total testosterone, and 34% had a reduction in their free testosterone. And in terms of symptoms, they were very non-specific. Wasn't really much difference in those with low testosterone or not. Then in terms of what types of hypogonadism are there? So this is from the EMAS study. So 40 to 79-year-olds, 3,369 men followed up. So you can see they've put a line at 10.5 on the testosterone, so on the x-axis. And obviously, ones to the left of that have hypogonadism, and ones to the right of that have a normal testosterone. And then on the bottom right are people with a normal testosterone and a normal LH, which they've defined as less than 9.4. So those they've called eugonadal. To the left of that, so in the bottom left, you have people with a low LH and a low testosterone. So that's secondary hypogonadism. So that was 12% of the patients. And then if the LH was high, that was primary hypogonadism. So that was only 2% of the patients. What was interesting, they also had this category in the top right of compensated hypogonadism. So these are people with a normal testosterone, but a high LH. And then in terms of symptoms, those with a low testosterone had sexual symptoms, but those with the compensated hypogonadism, they had sort of physical symptoms. So unable to do vigorous activity, limited in walking, unable to bend. So may or may not be related to testosterone. So then this is the same data, just categorized. So in terms of looking at male obesity-related secondary hypogonadism, so these are men with a reduced total testosterone in the blue. They had a LH that's slightly reduced or inappropriately normal. The SHBG was low, and the free testosterone was low, but not as low as the total testosterone. This is another similar study where they looked at 7,200 men that were referred to a urology center. So it was in the US, and the majority had overweight or obesity. And 46% of them had secondary hypogonadism, so the male obesity-related secondary hypogonadism. So they defined it slightly different. They used an LH of 8 as opposed to the EMAS, which is on the right. But one of the nice things they did is they categorized it by BMI. So you can see as the BMI goes up, it's the light blue secondary hypogonadism proportion that increases. So again, pointing towards secondary hypogonadism being the commonest thing that's associated with obesity. Of course, the Leydig cells don't just make testosterone. This is a sort of fairly recently investigated marker called insulin-like 3. So insul 3 is more of a constitutive marker. So it is reduced in patients with secondary hypogonadism or compensated hypogonadism, or primary hypogonadism. But what was interesting was also reduced in those with compensated hypogonadism. So as you remember, compensated hypogonadism had normal testosterone, but the INSUL-3 was still reduced, meaning that there was evidence of testicular dysfunction, but it could be overcome by the high LH and therefore have a normal testosterone level. So that's quite an interesting marker. Okay, so this is also in the EMAS study. So what are the chances of having secondary hypogonadism? So between a BMI of 25 and 30, the chances were increased threefold, and then over a BMI of 30, more than eightfold. So there is this idea that secondary hypogonadism doesn't happen until you get to very high BMIs, but there is also some indication that it can have abnormalities at lower BMIs. Okay, so tell me in the chat, are you convinced of the existence of male obesity-related secondary hypogonadism? Would you be happy to ascribe that to a patient as a diagnosis? No replies yet. Okay, so most people convinced, maybe. Not everyone is convinced. Okay, so this is an article by David Handelsman, and he's a key opinion leader in the field. And you can see the title is The Illusory Case for Treatment of an Invented Disease. So on the left, you can see what he would call classical hypogonadism, which is pathological. And then on the right, we have pseudo-hypogonadism or sick eugonadal syndrome, brackets functional. And you can see in the list of disorders, obesity is one of them, but also aging and chronic diseases. So he's suggesting it's more like a sick euthyroid type condition. And this is a very recent article that he's also written. So some really, really interesting thoughts. So pathological hypogonadism occurs when serum testosterone is significantly and persistently reduced by irreversible organic, bracket structural genetic disorders of the HPT axis. In contrast, mild or moderate reductions in serum testosterone frequently accompany obesity and its numerous comorbidities and are best considered non-gonadal illness syndromes. Obesity is not a cause of pathological hypogonadism, and proportionately reduced testosterone and SHBG, accompanied by normal serum LH and FSH, confirm a eugonadal state, best described as pseudo-hypogonadism of obesity. Okay, so some of it is obviously quite a visceral takedown of the field of obesity-related hypogonadism. Some of it, I suspect, might be a backlash against low testosterone campaigns where they were saying, check your testosterone, you might be low, we might need to treat you. And obviously, you know, trying to say people without hypogonadism could have a low T that needed treatment, which is obviously inappropriate. But in terms of the main arguments, it's mainly reversibility, the fact that it can be reversed with weight loss. So I do a lot of work on functional hypothalamic amenorrhea. There's also a metabolic dysfunction that can lead to hypothalamic dysfunction and lead to hypogonadism. You can say that perhaps FHA is more severe, but we heard earlier we could accept estradiol levels up to 200 in patients with hypogonadism, and that will cross over quite dramatically with healthy women in the follicular phase. It's also a reversible condition. He also says because the LH is normal, but that's half of endocrinology. We talk about inappropriately normal controlling hormones, and we don't necessarily say this is a sign of health. He also says there could be reverse causality. So if you have decreased sexual activity, that can then cause the low testosterone as opposed to the other way around. The other thing that he says is the degree of abnormality. So he goes, because it's often relatively mild until the BMI gets quite high, it's a sort of mild functional hypogonadism. But then quite interestingly, his main issue is mainly that he doesn't think there's a physiological need for treatment, but he's not against pharmacological androgen treatment for non-gonadal disease, which is also quite interesting. Okay, so on an unrelated note, I'd like you to join my campaign to rebrand type 2 diabetes as functional, non-organic, non-structural, non-pancreatic pseudo-hyperglycemia, or FNOMF. Okay, so in type 2 diabetes, the pancreas is intact. There's no structural organic abnormality. And so we can call this a non-pancreatic illness. It's a functional hyperglycemia. The symptoms are really non-specific, so things like fatigue. And in fact, half of patients are asymptomatic. And that's why half of patients are undiagnosed, so 30% for many years. And then even if you do treat them, they still have the symptoms. So it's not really responsive to treatment. It's also reversible. It's not permanent. If you have bariatric surgery, FNOMF will improve. And about half of patients over 65 will have dysglycemia, and almost 30% will have diabetes. And so are we just medicalizing a normal part of aging? Obviously, it'd be very common in obesity. Are we just trying to sell gliptins? And then also there's reverse causation. So high glucose reduces pancreatic function, and that could be the reason. So there'll be a link to the bio if you want to donate to this campaign. Okay, so let's say it did exist. What could be the cause in terms of where is the abnormality? So this is a study where they tried to investigate these men. So on the left is the LH levels in men with different BMIs. You can see that LH starts to fall even slightly overweight and obese men. They then did GnRH tests, and there was no difference in the LH response to GnRH, so no difference in pituitary function. As we said, testosterone is reduced, and also interestingly reduced at relatively low levels, and the free testosterone was also reduced at relatively low levels. And then they did HCG testing to look at the function of the testes, and there was no difference. So it wasn't due to pituitary or testicular dysfunction. So this is a review that we did where we looked at some of the sort of reported mechanisms. So leptin resistance in the hypothalamus to decrease GnRH is thought to be one. Adipose tissue has aromatase, which aromatizes testosterone to estrogen, which can increase negative feedback. Also inflammatory cytokines, and there's also some testicular effects of leptin. So should we be giving these men testosterone? So this is a trial of 100 obese men with a testosterone less than 12. They all had a very low energy diet for 10 weeks and then randomized to testosterone or placebo. And they found some improvements in body composition, so slightly more lean mass with the testosterone therapy. This is the type 4 DM, so it's a double-blind, placebo-controlled, randomized controlled trial, so age 50 to 74. They had serum testosterone less than 14, so which is a relatively high threshold. The idea is if you had frank hypogonadism, it's unequivocal that they should be treated. And also this corresponded with the threshold at which type 2 diabetes increased. And they basically randomized them to intramuscular testosterone or placebo. And again, they found less diabetes on an oral glucose tolerance test, so 21% versus 12%. So as you know, testosterone in men beneficial for dysglycemia or NOMF, and in women, adverse effects. Slightly improved weight and sexual function. So obviously the testosterone increased, DHT increased, but they also had increased estradiol. They had some negative feedback on the FSH and LH, which would make you concerned about spermatogenesis, and SHBG slightly reduced. But in terms of the negatives, there was an increase in hematocrit by 4%, and 22% developed a hematocrit more than 54%, and there was an increase in PSA. So as I mentioned, aromatase in adipose tissue is one of the purported reasons for hypogonadism in this group. So this is a once weekly aromatase inhibitor. So it's a randomized controlled trial, which would make sense. So inhibiting aromatase did increase total testosterone. And in contrast to giving testosterone, you have an increase in LH and FSH, a reduction in estradiol, and therefore improved sperm parameters. There was no benefit on sexual dysfunction. So as you know, Prof. Comninos is an expert in sex, and as he'll tell you, that estrogen is also important for sexual function in men. So that might be the reason. There was also this raised hematocrit, PSA increased, blood pressure increased, and because of this lower estradiol, a reduction in bone mineral density. So there was this recent review that looked at, I think I'm conscious I'm running out of time. Let's skip that. Okay, and does it affect fertility? So yes, so for each 3-unit increase in BMI, there was a 12% increase in fertility. So this is a randomized controlled trial from KNDy, where they randomized to low energy diet versus a controlled diet. So there was an increase in testosterone and SHBG and a slight increase in motility. So that was a shorter trial. This was a slightly longer trial. They had a low-calorie diet and randomized to exercise, liraglutide, or both. And in this study, which went on for 52 weeks, there was an improvement in sperm concentration and sperm count. But you'd think more weight loss might be better. So this is the data around bariatric surgery. So it's definitely good for testosterone and free testosterone, despite increasing SHBG, reduced estradiol. So it increases LH and FSH. However, wasn't beneficial for spermatogenesis. Okay, so in terms of overall takeaways, so secondary hypogonadism is the most common form associated with obesity. It's worth calculating or measuring the free testosterone. More weight loss is beneficial towards hypogonadism, but less so towards spermatogenesis. Testosterone could improve glycemia, bone mineral density, sexual symptoms, but at the risk of impairing fertility and increasing hematocrit and PSA. So in conclusion, treat the weight, and we've got lots of new agents to do that, to manage the hypogonadism, rather than treating the hypogonadism to manage the weight. So I'm conscious I've said lots of controversial things, provocative things, so you might want to return to 30 minutes before this lecture started and return to your state of Zen. And finally, this is the feedback form for the talk.
Thank you so much, Ellie. That was absolutely brilliant. So much to cover. And indeed, the presentation will be uploaded if you want to go back and look at some of the data. Really clear. Thank you, Ali. Just one question before we end this masterclass. MRI and patients presenting with secondary hypogonadism.
Would you do an MRI?
Then, so they're asking what are indications for MRI in patients, because it's quite common. So when would you actually ask for a pituitary MRI?
So I think the guide, so for functional hypothalamic amenorrhea is the sort of situation we come across this most often. I think there's basically a really low threshold. So they don't mandate it, but there's a very low threshold to do it. We don't always do it, but if you're at all unsure, generally we would.
Fantastic. Thank you very much. So it's 5 p.m. in the UK and I think 8 p.m. in Abu Dhabi. You've now got the QR code on screen or the link. You can just scan it and it will take you to a very quick feedback form. And then please make sure you spell your name correctly, because that will appear on your certificate that will then be emailed to you almost immediately. And please put 25th of April in your diaries. It'll be our neuroendocrine tumor masterclass, again with 4 really good talks on 25th of April, the same time. Okay, I'd like to thank our speakers again for 4 fantastic talks. These will be uploaded on the website for Imperial Center for Endocrinology, so you can access them again.